All right, let me tell you about our next speaker, that is Dr. Ellie Leister. We are honored to have you with us, first of all. Dr. Ellie Leister is a veterinary, emergency and critical care specialist and the veterinary director of the Pet Intensive Care Unit, PET ICU, in Brisbane, Australia. An experienced clinician, mentor, and educator, she leads one of the only dedicated standalone veterinary ICUs in the country, where she oversees a large 24/7 team delivering complex, life-saving care. Ellie is also a passionate educator and regularly speaks at national and international veterinary conferences. And it is an honor to have you with us today. Ellie has special interests in mechanical ventilation, transfusion medicine, and the treatment of tick and snake envenomation. She has presented at IVECCs and is a familiar face on the Australian veterinary education circuit, frequently speaking and teaching through continuing education platforms such as Australian Small Animal Veterinary Association, ASAVA, Improve International, VetPrac, and Centre for Veterinary Education, and ANZCV's Science Week. And now it's time to have a look towards her AV as well. A clip of beautiful moments combined all together for all of us to see. Yes, here it is. Applause, invite the lady who's perfect example of beauty with brain, Dr. Ellie Leister. Over to you.
I just wanted to start by saying thank you. Thank you for having me here. I feel very privileged to be here with my husband and my little daughter and embracing your culture and your hospitality. We've had a lovely few days to start. So these next 3 days are really all about you. I really hope to share some knowledge and empower you to take on new things, try new things, push your boundaries. It's something where I think you saw the photo of me with a little miniature horse vaccinating it for equine influenza, because I didn't start out at this level. You'll see that I obviously work now in a very high-end ICU, and we have equipment on par with human ICUs, whereas where I started was in general practice, with not much, very basic equipment, but it made you think, it made you push yourself and think outside the square and do the best you could with the equipment you had. So that's what I'm really hoping for you to take away today. The first talk I'm going to go through is managing that trauma patient. And trauma can be scary. I know when I sometimes still my heart will race a little bit as a severely injured animal turns up, normally with a very distraught owner beside them. And this is life and death. These trauma patients are very critical, and how you respond and those first steps really make a difference. This session, we're going to go through the first hour, that primary survey and how to rapidly assess your patient, followed by the immediate stabilisation and providing the life-saving things of oxygen and fluids and pain relief. The systematic secondary survey, which I'll use an acronym, a crash plan, so that you can actually remember everything you need to check through to find any of those injuries that aren't initially evident. We'll go through some common trauma presentations, and then I'll have some key take-homes. So the first hour, I'd like to call the survival hour, and unfortunately for this little dog, these patients can turn up arresting or already dead as they arrive. the degree of trauma has just been too much for their little bodies to handle. However, there are some patients who turn up who we can save. And being aware that that cardiovascular and your respiratory system is your two most important systems that you should be aware of in that first hour. Intervention and treatment must be immediate. So you need to be able to see and respond and act. So the golden rules for this is that you're going to attend the most life-threatening problem first. You're going to minimise the stress to these patients. They're often already on the edge cardiovascularly. So restraining them for a diagnostic or even a blood test or a catheter, if they stress, that can really tip them over the edge. So doing everything gently and calmly and using drugs in your favour. Don't panic. So that's another key one. I see some of the younger vets, they kind of almost will freeze. It's hard to say to you, don't panic. It's experience and time and confidence and knowledge that ends up with you being able to actually do this. And having a team around you. If you've got experienced nurses, other vets, know that they're there to support you and work with you with these patients. So the primary survey. This is something that, again, I hope we've all been through. I'm going to give you my take on this in the trauma patient. So we're going to go through their airway, their breathing, their circulation. I call it D for disability, which is really what kind of deficits do they have neurologically in their mentation, their deep pain, what other injuries have they obtained. And then E broadly covers everything else. However, in this primary survey, we're really concentrating on the life-threatening conditions. So again, don't panic, just go down the alphabet and try and make it seem easy. So the airway exam. In a trauma patient, they've often been hit by cars or dog attacks. They can have fractured jaws, fractured skulls. This little cat had actually been through the washing machine and done a full cycle. Its little tongue was horribly lacerated, and on the presentation on the crash bench, its mouth was obviously full of blood and clots. We couldn't really tell what was happening, but calmly examining that patient and being able to open her mouth, we could feel that the jaw wasn't fractured, and you could get a good look in. So don't be scared of actually assessing that airway best you can. If the patient's going to stress and struggle, abort until you've got more pain relief on board or maybe a little bit of sedation. So I'm asking myself, is the airway patent? So are they moving air? Sometimes they'll look like they're breathing, but they're actually obstructed from swelling, from clots. All sorts can be happening in these trauma patients. So you really want to make sure that they're moving air initially. Do they need to be suctioned in their oropharynx area? Is there blood? Is there saliva? And we'll have suction ready at our crash bench. In my talk on CPR, I'll take you through a little bit more on how being prepared and what we have set up. And are they able to protect their airway? If they're a severe head trauma or they're in severe shock, they may actually not even have a gag or a swallow. And those patients are safest actually if putting a tube in them with an ET tube. So if they're unable to protect their airway, we will intubate them because initially we can take over, we can breathe for them. We can always take a step back and take that tube out once they're a little bit more aware or we determine what degree of injuries they have. So for breathing, we're going to assess your respiratory rate and effort. And all of these things so far, we're just doing with a physical exam. I'm going to be really looking at what kind of inspiratory effort do they have. I don't know why we've just gone off. I'll be listening to their lungs. Can I hear lung sounds bilaterally? You really have a good look at their thorax. Is there any fractured ribs? Is there a flailed chest? Are there wounds over their thorax? What can I see just visually and quickly? And all of this, I've started with airway. I often like to say, and I'll teach the interns and students, is I start at the nose and I work back because I just know I don't miss anything that way. You get a routine where you do it the same way every time. So back to breathing. Is there hemoptysis? So are they coughing up blood? It's giving me a sign that there might be some bigger injuries or degree of pulmonary contusions internally. Are they really restrictive breathing where they might be really sucking in with a inspiratory phase? That might point me towards the pleural space. So I'm thinking about a pneumothorax or a hemothorax. If the patient's critical and we're unable to move them to x-ray, and a show of hands, who's got x-ray in their clinic? Spattering, maybe about a quarter to a third. And so if you don't have x-ray and they're really struggling to breathe, a diagnostic thoracocentesis with a small needle where you're going to pop in with a butterfly catheter and see, are we getting air or are we getting fluid? Sometimes these patients are too critical to move. So that may be indicated. This is a little patient again. Oh, actually, that wasn't a video, don't worry. We then move on to your perfusion parameters. So you've got your 6 perfusion parameters. And again, this is something all from your physical exam. I'm going to repeat these a fair few times over the next 3 days, so hopefully they'll be embedded. You're going to take your heart rate, your mucous membrane colour, and your CRT. Your pulse pressure, so I'm feeling the pulses as I'm listening to the heart rate. And I'm feeling for how those pulses feel. Are they bounding? Are they weak? Are they thready? For people taking pictures too, all of the talks will be distributed to you at the end as well, so you can have a copy of all of these presentations. And you're also looking at your peripheral limb temperatures. So these 6 tell you a hell of a lot about what status the perfusion for that patient is. Are they in shock, I guess, is the big question. So for circulation, I'm looking at these. Plus, do they have an arrhythmia? So even if I've just got my stethoscope and I don't have the ECG on them yet, can I hear an irregular heartbeat or feel an irregular pulse as I'm listening? Is a heart sounds muffled? That might incline me more towards, is there something in the chest that shouldn't be? Air, fluid, even a diaphragmatic hernia. Is there a heart murmur? So maybe it's a Cavalier King Charles or a little small white fluffy, and there's actually underlying heart disease. So now I've got my trauma patient with heart disease. External hemorrhage or internal hemorrhage. The external stuff is pretty generally obvious to see. We have them go through glass, smash through glass doors and lacerate arteries, and they're pretty obvious, and you can get those pressure bandaged or ligated off. But internal hemorrhage is something that you've often got to have the suspicion for from your perfusion parameters that they're actually bleeding inside. Most cardiac arrests are preceded by respiratory arrest, so those first 2 are so key because that's often how they arrest and die. So our clinical signs of shock are the pale mucous membranes. They can be almost white when they present on the crash bench. Prolonged CRT, tachycardia, so a high heart rate, low pulse amplitude, those thready pulses when you're feeling their femoral pulse, cool extremities, and that can happen quite quickly as the circulation, they'll vasoconstrict, trying to send their blood to all the important organs and take it away from the peripheries. Their limbs will feel cold and they'll be obtunded. So checking these 6 and rechecking these 6 as we resuscitate them can tell you so much because they can change. You give this patient some pain relief and a fluid bolus, everything can look better in minutes. So in the trauma patient for disability, and because this is our primary survey, I've normally done those first 3 very quickly, and I'm kind of doing a cursory glance over these. I may not have gone into as much detail. Generally when they're in shock as well, it's very hard to assess their level of mentation, We're looking at their PLRs. I'll look at just their eye positions. Are they seizuring? Do they have spinal reflexes and deep pain? What are their cranial nerves doing? Deep pain and proprioception. And are there any obvious head, neck or spinal fractures? So shock can affect all of these, but I keep repeating this exam as we stabilise them. If they've got poor deep pain, I'm not going to go and tell an owner to stop now. We're going to resuscitate them and give them time, because you'll be amazed in the difference they can be. So E is for everything else in our primary survey. Again, this first survey, I do a very cursory abdominal assessment. I'll try and palpate a bladder. If I can't feel one, initially I'm not as worried. They might have just urinated, but I know it's on my list. I want to actually look in with the ultrasound and be sure that I've got an intact bladder. Are there any hernias, or, have I got inguinal hernias, abdominal hernias? What other wounds have I got over the abdomen? What other bruisings coming out? Are there any obvious fractures? Any other form of trauma, really, I'm kind of looking for. Are they too hot? Are they too cold? What's their body temperature doing? So this primary survey is what really helps you go, what do we need to do? So I may have had to intubate them. I may be aware that they're bleeding, and I'm worried about internal bleeding. But in the next few steps, we keep working through. So we're going to give them oxygen therapy. We're going to get an IV catheter into them. We're going to start some pain relief or sedation. So pain relief in our hands, we like, again, on a trauma patient, a methadone injection, because it's going to have a bit longer lasting than, say, fentanyl. And it gives me time to get once we get some diagnostics done or have them a bit more stabilised, then I can start a CRI of analgesia to continue on with. Methadone I can give it, if we haven't been able to get a catheter in quickly or easily, I might be able to give some IM, which can take even about 10 minutes to become active. If they're really stressed with the situation, difficult to handle, trying to bite, we may sedate them. The kindest thing is to keep them calm. A little bit of midazolam have minimal effects on your cardiovascular system. So we'll use these in preference than acepromazine or medetomidine. If we get that first catheter in, we often can collect bloods from the catheter, so they don't have to have another blood test or restraint and handling for diagnostics. Who has in-house blood machines? Yeah, again, a spattering. So something where we'll collect a packed cell volume and total solids. We'll take a blood gas and get a lactate. Who gets lactate on their blood tests? Yeah, a couple of hands. Lactate's great for a marker of perfusion and shock, and we can trend improvement or deterioration. However, if you don't have all of this, physical exams, repeating them and reassessing those 6 perfusion parameters can almost tell you more, I feel. Sometimes we get caught up on these blood tests and we're looking at numbers and not the patient. We will do coagulation testing as a baseline. Acute coagulopathy of trauma, which I won't go into detail about, but the combination of the trauma and the effect on their glycocalyx and all of their cardiovascular system can then combine with acidosis and getting hypothermic can make the perfect storm to coagulopathy. Depending whether they've had previous hematology or biochemistry run, we'll hold that. If they're a healthy young dog, we may not run it. If we're worried about comorbidities or the owner's umming and ahhing if they're going to go ahead because they're not sure what else, we may actually do a bit more diagnostics and run the full biochemistry. So oxygen, and again, I show of hands who's got readily available oxygen that you can just turn on and go. Yep, again, a spattering. This is something where if you've got oxygen, great, give it to them. I'm going to step you through actually how easy it is to make oxygen cages and have Oxygen generators are humans who have to stay on oxygen long term in the homes. Have anyone got family members on a little oxygen generator? It's a little box that chugs along. You can use these in veterinary hospitals. They only produce 5, max 10 litres per minute, but they're making oxygen from room air. So we can either give flyby. Initially, this is a head trauma patient, so we don't want to be sticking things up his nose. You can use your line. You don't get as good a FiO2 when you're doing it over on the left. However, with the mask, it can be quite efficient. You can put an oxygen line in by putting a nasal catheter in and gluing it in, which we may do when we're having patients on oxygen longer term. So they've got pulmonary contusions and they might need oxygen for a few days. We're going to get these little, they're actually feeding tubes, nasogastric feeding tubes. We measure to the nasal meatus, and we just slide it in medially and ventrally, and all it is a bit of super glue around the corner and a few dabs up the top, and you can keep that line in and hook that up to your oxygen line. You can use little nasal prongs, which are commonly used in humans. The dogs seem to tolerate these pretty well. They're very easy to put in. You're not trying to stick things up their noses far. You can buy these little buster cages, which you can have all the small dogs fit in quite nicely. Larger dogs get a bit hot and bothered and don't like them as much. Or you could even just get a cat cage and wrap it in Glad Wrap and put Glad Wrap around the door and put your oxygen line in. Where you get your oxygen from is either bottled or, as I said, I feel over here it may be that there's a place for these little oxygen generators. You have the outlay of the cost once, and then it just uses room air to make its own oxygen. And it's something that could, again, give you some oxygen. It's not massive fast rates, but it may be better than nothing. Then all you need is a little bubbler, and that'll humidify it as it goes in. So your oxygen needs to either come out of the bottle or the concentrator. That line then lets you give it to nasal lines, into a cage, or into your mask. So all your options. So what next? We're going to be doing our fluid resuscitation. It's normally an isotonic crystalloid. We're reaching in our hospital is Hartmann's or lactated ringers is our most common. It's got a buffer in it. It's more balanced than saline. But if saline's all you got, that's okay as well. I'm going to give 10 mils per kilo in incremental boluses. The old school just dialing up the shock rate of 90 mils per kilo per hour. I like to give it in boluses, see the response that you have from it, and incrementally titrate it up, because fluids are a drug. And if we overhydrate our patients, which I'll get into our fluid talk, you could really bring them undone, and we can do more harm than good sometimes. So you assess your response to that initial bolus, you recheck those 6 perfusion parameters, and you'll be surprised. When you start looking at those regularly, you'll be surprised at how quickly they change, and they can guide your therapy very well. You're determining if there's internal hemorrhage, because if there is internal, say if we've got a fractured spleen or liver, we're not going to aggressively give them crystalloids. We will be a bit more cautious until we determine that bleeding stopped, because just diluting them out with crystalloids is probably not what they need. Those patients more likely to need blood products, and we keep their blood pressure slightly on the lower end, trying to preserve that clot formation. So again, I like Chris's checklists. We have checklists in critical care as well. Assess your ABC mostly. D&E you're starting to think about. You're going to give them oxygen and pain relief. You get that IV in and start fluids. And all of these are kind of happening simultaneously. But if you're just you doing them, I'm probably going to do them in this order. Control any bleeding and keep reassessing these patients. So don't need perfection, you just need to prioritise. The next window we move into is kind of called the golden period, where if you can get things right in this period and you can determine the degree of injuries, have more of an understanding of what you need to be supporting and stabilising, and make sure you resuscitate them well, because an under-resuscitated patient So if they haven't, just not progressing that's not working anymore. Oh, there's just a lag there. Sorry, guys. So we're determining the extent of injuries and you're reassessing. The secondary survey helps you find out what else is wrong with them. And you also pick up on anything you might have missed. And I'll say to these owners, it may take us a few days to determine the extent of the injuries, and things are going to get worse before they get better. So you expect the unexpected in these next few hours and even days. Nature normally sides with the hidden flaws, so if there's something we're missing, it's likely to go poorly. Don't place the patient at risk to achieve a diagnosis, so really forcefully restraining them, moving them to imaging, all of those aren't going to go in their favour if they're very critical. And when in doubt, reassess your patient. So this secondary survey, and this is something you'll get in the slides and in your notes, it's a really good acronym just to make sure I don't miss anything. I restart again now that we've got the patient a bit more stable and I can take my time a little bit more. I'll re-go through my airway, might go across the circulation, re-look at the breathing. Are we going to get radiographs by now? Rectum, things like that are still in your R. So it makes you go through and systematically check your patient. What's happening in the abdomen? What are the wounds doing over that area? What analgesia? Should we be checking the bladder? Am I going to do a focused ultrasound? Their spine and neurological exam, you've often given them some fluids, some pain relief, they're looking a little bit better and you can get more of an assessment on them. What degree is there a head trauma? What wounds do we got over that head and neck area? I'm thinking about hydration, hypothermia. And then you move through your pelvis area, your limbs, any arteries or superficial arteries, and your nerves. So it's just a nice acronym to go through. Your other way of doing it is start at the nose of the patient and systematically work your way through, examining everything, making them, even though they seem like they're painful, be gentle and kind, but ask them to stand up. See if they can weight bear on all of their limbs. We've had them where if we leave them recumbent, we fill them up with painkillers, no one actually goes and stands them up to find that they've got fractures in their digits and not weight bearing, or something that the surgeons then are stepping in and starting to look at with us. So definitely make them up and stand and assess them properly. So moving into our next 3 to 7 days is a critical recovery window. Most delayed deaths occur. Bad dog attacks that they're covered in bite wounds that are very deep and tip of the iceberg. Those ones are really at high risk of sepsis, multiple organ dysfunction or arrhythmias, all of these trauma patients, because the trauma can be just so severe that the overwhelming inflammation and tissue damage is too much, and these patients can't survive no matter what facility and what level of care we can provide. So frequently reassessing, I keep saying that. Again, golden rules, look, treat the treatable if you can't get a definitive diagnosis, but that generally comes. Once you've got them stable enough, you can get them imaged, get x-rays, refer them to another clinic that can x-ray them for you. So left to themselves, don't ignore things, is my key point. They will go from bad to worse. And if everything seems well, you're probably overlooking something. Criticalists and hospitalists, we're constantly worrying about our patients. We think the worst is happening. The surgeons are often a little bit more optimistic and ready to send them home. So in this last part, I'm going to go through some common trauma presentations. We're going to touch on pulmonary contusions, pneumothorax and hemothorax, the rib fractures and flail chest, and the diaphragmatic hernia. I will also go through head trauma. So these are the ones that we really need to stabilise before we let the surgeons near them. Just for completeness, I thought I'd put up the talks that Chris has coming over these next 3 days. We'll cover off on different areas of trauma. Trauma, we could, again, talk for days on. There's a lot to cover. So the thoracic trauma, I'm thinking of the pulmonary parenchyma, so your lower airways when you've got pulmonary contusions. If I'm thinking of what's happening in the pleural space, have we got fluid, so hemothorax or air, and the thoracic wall, rib fractures and flailed chests, or the diaphragmatic hernia. So pulmonary contusions, this is a lateral radiograph of a dog. You can see that fluffy alveolar pattern where those lungs just look really white. That's full of fluid, that's blood. And I guess I kind of think of it and I explain it to owners, it's lung bruising, really. Those lungs are severely bruised, lots of those little alveoli are damaged and full of blood. And that's going to take time to resolve. There's an interstitial alveolar pattern on X-ray. They have rapid, shallow breathing. They're really fast breathing normally. They may have been coughing up blood or just have blood in their mouth, which can be deceptive. You think they've bitten their tongue or something. It's actually they're coughing it up, so be aware for that. They get worse before they get better over the first 24 to 48 hours. Another really key thing to tell owners, because they initially present and their contusions may not be that bad, then that patient gets worse in front of your eyes over 12 hours to a point of needing ventilation. They will resolve in 3 to 5 days, sometimes even sooner, sometimes a day on oxygen, and especially young puppies, they seem to really bounce. But they can be severe and we can need to mechanically ventilate them. They cause severe hypoxia and they can arrest from this. So we delay any general anaesthetics for any fractures or wounds. This little dog came off the back of a ute in Australia, doing about 80 k's an hour, and that was actually her lungs on the X-ray. She had oxygen. We avoided aggressive fluid overload. These lungs, we don't want to get these patients with any degree of pulmonary edema on top as well. We kept her really well analgesied and quiet, so actually sometimes sedating them as well. You don't want them ricocheting around the cage, pulling their oxygen lines off and getting stressed. So keeping them calm will reduce their work of breathing. So the patient that turns up with a restrictive pattern, and we call them air hungry. They just look they're struggling to breathe. If they've got dull lung sounds and dull heart sounds, are you thinking pneumothorax? Bear in mind, take this with a grain of salt. Sometimes I can't, when I listen and then I take the X-ray, I can't actually correlate what's happening, but sometimes you can. If you've got dull lung sounds and normal or muffled heart sounds, is that a sign of hemothorax, so the fluid more sitting ventrally? We're going to get X-rays and ultrasound if you've got the ability to, or a diagnostic thoracocentesis, which I'll step you through in a second. The pneumothorax will initially drain, and if we're doing multiple, that builds up again quickly, I might do 1 or 2 where I'll drain them just with a needle and the syringe. But if I'm needing to do that again, I'll consider putting in a chest drain and they may even have to go on to continuous suction or intermittently, continually emptying that chest out if you can't do continuous suction. And you keep that chest empty for a day, and often a lot of these traumatic pneumothoraxes seal themselves over. You just need to give them time. The hemothorax, we kind of take enough off till the patient is stable. And do they need that blood back? The blood that's in the syringe could very easily go back to them, which I'll talk about tomorrow morning, rather than putting that blood in the bin. So this is a patient who presented to our hospital, hit by car, really struggling to breathe, you can see there. This is on ultrasound. You can see that big, deep pocket of free fluid, and that was a hemothorax. Enough that we really did need to take some off to get that patient more stable. This is a patient who has a pneumothorax, so you can see the classic lifting of the cardiac silhouette, and that air, seeing the air all down there ventrally is a classic for pneumothorax. When you've got a hemothorax, getting all of the leafing of the lungs up the top, and you can see that increased density and all of that fluid sitting through the front of the chest. For a thoracentesis, not every patient with air or blood in their chest need a thoracentesis. If they're coping with it and their breathing doesn't look too bad and their oxygenation is okay, we may just monitor. They'll reabsorb both air and blood from their chest. Oxygen helps them reabsorb the air even quicker, but if you need to, you're going between the 7th and the 9th rib. So I just count back from the 13th till I get where I kind of roughly need to be. If it's fluid, I'm going to put my needle in about the bottom bottom third the way down, thinking fluid sits down ventrally. If it's air, I'm going to go in the top third. If I'm not sure, I just go halfway. You can't really go too wrong. You're going to aim more for the cranial aspect of the rib because the vessels run down the back. Whether you use a needle, butterfly catheters are nice because you've just got the little wings you can hold on to, give it the extension set on them. Sometimes I'll just use an 18 gauge needle, or you can use a large 14 gauge catheter, and you may need to repeat it. Are you going to auto-transfuse that blood or put a permanent drain in? So this is the setup. This is a butterfly catheter for a thoracentesis. You've got a 3-way tap and your syringe, and you just keep turning your 3-way tap for when you want to empty your syringe out, and then return it the other way and you can continue to draw. I've got a little video if you are using, and this is more, I kind of do this technique more for the abdomen, which I do go through in the auto-transfusion talk, is you can take little nicks out and fenestrate it, just in case, like for when you've got omentum, especially when you're doing this in the abdomen, or fibrin or adhesions, that nicking of the side of your 14 gauge catheter just lets you get it runs a bit freer and a bit quicker. So rib fractures and a flailed chest, these are often really obvious. The whole side of the dog will be ballooning out and they can look really crazy. I'm often surprised at how well these little dogs can do, but I'm thinking, do they have contusions? Are they hypoxic, so they're often needing oxygen? They're painful, so they're not wanting to take big deep breaths. So we're wanting to get good analgesia into them. If it's from dog bite wounds, again, like Chris's opinion, our surgeons sometimes, it depends on the degree of the wounds to whether or not we're going to definitively explore them and flush and lavage or conservatively manage. A lot of the time, even if it's dog attacks, I feel these flail chests we actually manage conservatively. Definitely blunt trauma, we have a conservative approach. We lie the patient flail side down. They often don't like that and they do seem to flip onto the other side, but if it's a really big flail, putting it flail side down will help them oxygenate and ventilate and move their chest. They are painful. We're giving opioids, fentanyl or morphine or methadone. You pick your pure opioid is much better in these guys. You can add ketamine to the mix or even lignocaine. You can do nerve blocks. Unless they're going under general anaesthetic, they don't really like you going in and doing nerve blocks consciously. And there's always concurrent pulmonary contusions. They generally very rarely need surgical stabilisation. So here's a little dog. And they surprise you, as I think that video is a bit longer. They'll surprise you how well they can actually cope with it and how well that actually improves and heals without us actually doing anything but supporting them. Is it another little dog? So they can be quite dramatic. Diaphragmatic hernia, so if you have a sudden increase in your intra-abdominal pressure, all that abdominal contents can go where it shouldn't, and you'll get a diaphragmatic hernia. You can get your liver in the chest, you can get your stomach in the chest, you can get intestines in them. Sometimes they can be very subtle and difficult to determine, and a radiograph, we've missed them, we've all missed them. So definitely tracking the diaphragm. Again, this one's a little bit hard to tell, but there's something where it shouldn't be, really. If you don't get that lovely crisp line of the diaphragm, take another view, and you should always be doing 2 views anyway, at least 2 or 3, do 3. Is you really want to make sure that diaphragm's intact. You can put the ultrasound on, and even if you're not quite sure what you're doing, you're looking for stuff that shouldn't be there in the chest. If you can see loops of intestine or a bit of liver too far forward, you've probably got something going on that shouldn't be. When we're stabilising them, we'll elevate the cranial half of the body, trying to get everything to slide back. And if the stomach's in the thorax, that's an indication to immediately go to surgery. Those patients just aren't cardiovascularly stable. We'll try and stabilise them as much as we can pre-surgery, but they aren't one that you're going to wait a day or 2 for taking them to surgery for their diaphragmatic hernia. We'll finish up with some head trauma, and then I've got a little case to show you. The pathophysiology of head trauma is that there's that primary injury to the skull from that initial impact. It's direct mechanical injury to the brain. There's secondary injury, is the damage that occurs in the coming hours and days. And it ultimately leads to a worsening of the cerebral injury due to increased intracranial pressure. Our goals is we want to maintain the perfusion and oxygenation to the brain. We want to reduce the edema and venous congestion and protect that mean arterial pressure, which is the main driver of getting the blood into that brain. These again can look pretty spectacular. This little dog had all these frontal sinuses ballooning out, and it's amazing what pain relief, oxygen and analgesia, this dog made a full recovery without us having to do anything more. Neurological assessments can be really important in monitoring the improvement or deterioration of these. The modified Glasgow-Coma scale, you can get this online, is a really good way of your whole team scoring them. And so from day to day, from shift to shift, we're a 24/7 hospital. Our nurses do this in our head trauma patients every 4 hours. So we can track trends of improvement or deterioration and intervene, because if they're deteriorating and getting a worsening in their score, so worse is a lower number, it may actually make us give another dose of mannitol. Relook, is there anything else we can do further to stabilise this patient? What's their blood pressure? Do we need to improve that to try and improve their perfusion of their brain? It can help with prognosis, and there's a linear correlation between survival and your actual score. A little bit of pathophysiology. So the cerebral perfusion pressure is the net pressure gradient of the blood flow to the brain. So you think of the brain like a hard box. It can't swell and move with the increased swelling and pressure within the brain. So something's got to give. So your mean arterial pressure's coming in, and if you have an increase in intracranial pressure, we're getting collapsing of all those little blood supply, all that blood supply, and you're getting a poorer perfusion because it can't push through that pressure. In our trauma patients, it's intracranial bleeding and intracranial edema that's getting us into trouble. This is where this vicious cycle comes in. If you have an increase in your intracranial pressure, you get a decrease in the perfusion to the brain. Your brain doesn't get enough blood, so you're getting ischemia. Then you get more edema, which causes an increase in intracranial pressure. So we're really trying to halt all of this with the treatment of our head trauma. So we're using, there's this, again, vicious cycle. So the treatment, we're protecting that blood pressure to the brain. So you want to appropriately fluid resuscitate them. Sometimes they may even need vasopressors, so dopamine or noradrenaline if they're critical. Mostly it's just generally appropriate fluid resuscitation. You want to control seizures, we'll give them diazepam or midazolam. A patient whose seizures on the crash bench, it's not prognostically indicative either of outcome. I've had plenty of patients seizure on arrival and go home in a few days. So don't write them off because of a seizure. Keep them comfortable. If they've got other injuries and they're a polytrauma, I'm going to give them opioids. We can't expect to be minimal on the pain relief with them. But if they've just got head trauma, I may actually, paracetamol is quite nice and it lets me keep assessing their mentation, because these guys, I think, just have really severe head. They look like they've got a horrible headache. Paracetamol is actually quite a nice analgesia in dogs. We're using it more and more. Probably the dose rate I should have in there is closer to the 15 to 20 milligrams per kilogram. You can give it IV. Do you have the IV formulation over here? Yeah, you can get it in IV. It's the human formulation that we use, and we give it slow IV. You want to avoid your CO2 getting too high. You'll vasodilate in that brain, or CO2 too low. So some of these really obtunded dogs, we may actually put on a ventilator for a day just so I can control their CO2. You're going to put them at 30 degrees to help with venous drainage, so trying to do everything to get the blood out of the brain and decrease pressure. We're not going to hold jugulars off to get blood tests from them that way. We're going to give them mannitol, so I'll give a quarter of a gram, half a gram to 1 gram over 20 minutes, or hypertonic saline, and that is followed by a crystalloid as well, because that gives a transient shift, and then you do need to follow that with a crystalloid. I'll go through this more in your fluid talk. Steroids are contraindicated, so we don't give head traumas steroids. And there's been big human trials showing that they actually have a worse outcome if they're given steroids. We avoid sneezing and nasal lines, and they definitely may get worse before they get better. So finish up on a case. This little fellow was the one I showed you the video of him on the oxygen before. He presented, been hit by a car. He pretty much looked like he was dead on the crash bench. Not responding, no deep pain, just seemed like no one was home. But he was just lying there and breathing. He came into ICU, he was on oxygen, pain relief fluids. This is 14 hours later. And so his modified Chroma Glasgow score was improving. We could obviously see that with his meditation, but you want to put a number to it, you're going to see that improving. They start becoming more and more aware. If the audio was on this, you'd hear the nurses calling his name out and talking to him. 28 hours post, looking almost like a little normal dog, still a little bit worse for wear, probably a horrible headache. Day and a half later, got up and did first wee, and then able to walk. So definitely giving these guys time. The difference I've had in them from 1 day to 2 days, is dramatic. They don't need to read or write like humans. So when you're talking, recovering these dogs from head trauma, I think some of them may not quite be themselves post. Generally, they do make a full recovery. Straight into stealing some cat food in another cage, I think now. And they get home, and their owners send you in videos like this. So I think just for the key take-homes for trauma is it can be daunting, it can be scary, but if you be calm and systematic, some of these patients can make amazing recoveries with minimal interventions and minimal fancy equipment and not even need the surgeon. So, but thoroughly assess them. It's easy to miss things, and things can come to light later. So cover yourself when you first talk to these owners. Explain that trauma can present and keep evolving. Again, ICU and the emergency guys at our hospital, we do have a Facebook and an Instagram, and throughout you'll hear me talking of different protocols and things. We actually share all of our protocols online, so that Vetopedia is actually within our main page on the animal emergency site. We have an education tab, you can get to it there. A lot of our cheat sheets, there's drug dose rates, CRIs, all of that we've shared on there. And you can have a hunt around our site and see what we do over there if you're keen. Any questions? Oh, yep. Oh, I might get them.
The use of paracetamol in controlling the pain. We observed a lot of hepatotoxicity and methemoglobinemia and other things.
What dose rate are you using?
We go for butorphanol,
Oh, yeah, so you're using butorphanol.
yeah, instead of paracetamol.
Yeah, sure. What dose of paracetamol are you using to see the complications?
Actually, acetoaminophen. The chemical compound is acetoaminophen. Actually,
Yep.
normally we avoid in dogs and cats.
Yeah, okay. We're using acetaminophen and paracetamol, same. Those dose rates we're using, we haven't, generally, is very well tolerated in dogs. We don't want to overdose them, and we definitely don't want to use it in cats. But butorphanol will give you good sedative effects. I sometimes find the analgesia from butorphanol doesn't give us enough pain relief. But yeah, that's still a good point. Definitely watch out for their liver.
Thank you, ma'am, for the wonderful lecture. I want to ask, like you told about a flail chest condition, lie the patient on the flail chest side down. But won't the rib fractures cause trauma to the lungs?
The fractures? No,
Yeah.
they don't. They don't seem to.
sure.
They seem to cope really well. Often those fractures are still within the musculature of the lungs. They're not poking straight out. Sometimes they can be, but no, I haven't had a problem with that. If they don't like it, they flip themselves back onto the other side. It's just something to try. If they're not ventilating well, I'll try them downside, and it seems to help them. But all right. Thank you.
Thank you so much, ma'am, for sharing your expertise with us with such clarity and depth. I won't take much of your time because the tea break is already cut short, and we will again start our next segment at sharp 5. So this is your cue to get up, go freshen up, have tea, and come back at sharp 5 p.m.
Sure.
Thank you.
What I might do is I'll get an email. I can send you my talks.